So inflammation. What is inflammation? Well, everyone knows when something's inflamed. It's red, hot, it's swollen, it's tender. You get your immune cells, your blood vessels, molecular mediators. The body senses cell injury. It wants to get rid of that cell injury, But what about a low-grade grumbling infection? What if your car just isn't running quite right? It's not idling quite right, but it's, burning oil. Most of us wouldn't know the difference between that, right? And that's what's happening with our bodies. So is there any way we can measure that? So there are blood tests that we can pick up severe inflammation, such as your white cell count, because if you get an infection, you throw out lots of white cells and the white cells start dying. But what about a very more subtle test? Well, this is where the CRP, or C-reactive protein, comes into it, sometimes called the HS-CRP or the high-sensitivity CRP. But essentially, they're all the same. This is a very, very sensitive test of inflammation in your body, but it's non-specific. If you've got a urinary tract infection, if you've got a chest infection, if you've got general inflammation, all of these things make your CRP go up. You go do a massive workout where you damage your muscles, your CRP is going to go up. So it's not an individual reading that's important. You can't take an individual CRP. You've got to track the trend of CRP over time. So it's something that's produced in the liver, and you can use older tests such as an ESR or an erythrocyte sedimentation rate, but that's slower to go up and slower to go down, so is less useful. Now, the risk of developing type 2 diabetes increases massively as your CRP goes up. So if you're eating inflammatory diets and you have more of these AGEs and your proteins are getting oxidized and inflamed, your CRP is likely to go up and you're likely to end up becoming a type 2 diabetic. I'm not going to mention the other 6 markers of inflammation. That's just beyond the scope of this talk. Now, 80% of type 2 diabetics sufferers globally are overweight or obese at the time of their diagnosis. Now, if you're obese, you have a 65% higher chance of getting arthritis. Hey, I'm an orthopedic knee and shoulder surgeon. I see you guys, well, not you guys, because you're all looking fantastic, but the patients that are overweight and obese and have knee arthritis, that's how I got involved with this in the first place. You've got a 9 times greater chance of getting type 2 diabetes. You've got double the risk of having a heart attack. You've got a third the risk of having a stroke. And if you're obese, you are much more likely to get an infection after your knee replacement or have a redo knee replacement in 10 or 15 years. So you recall the fats I showed you. So we're going to talk about polyunsaturated fats now for a little while. And we're going to talk about these omega-3 and omega-6 fats. Again, complex slide, don't worry too much about it. What you need to know that there are things called iconosoids. And basically at the end of this pathway from omega-6, you end up with these. At the end of omega-3, you end up with these. The red ones are pro-inflammatory. The green ones are anti-inflammatory. And in fact, there are medicines which are anti-inflammatory tablets which basically work here to stop this happening because we know that that will help with getting rid of inflammation. Now, both of them have the same enzymes being used to convert them from the omega-3 down to the iconosoids and the omega-6 down here. So if you've got more omega-6, these enzymes will get used up over here and you won't produce much omega-3s. But if you're producing more omega-3s, by definition, you're using up the enzyme and you're not going to produce as much omega-6s. So you get more anti-inflammatory and less pro-inflammatory mediators. So that's very important. So cell membranes are complex structures. It's what's called a phospholipid bilayer, and it's made up of fats. They contain 5 types of fatty acids, including omega-6s. So if we don't have omega-6s, we die. We need omega-6s. We just don't need them in excess the way modern society has now. And you remember that we made lots of seed oils. Seed oils are high in omega-6. We were told not to eat fat. What did we use instead? We used fat seed oils. We're getting lots of omega-6s. Now, one of the other things that people talk about is smoke point in food. Oh, you can't cook with extra virgin olive oil because of the smoke point. Now, I did a lot of research into this because it's something my wife and I were talking about at home. I've not been able to find any evidence that the cooking in any form of olive oil or coconut oil or any of these oils creates cancer by eating the food. There is some evidence that if you recurrently inhale the smoke from burning the olive oils in an enclosed environment. So a lot of the study comes from Hong Kong, where people are cooking in very closed environments with no ventilation, inhaling the smoke all day, every day for long periods of months or years, and it's only the chefs that this seems to happen to. Maybe there's a problem with that. But the amount of cooking that we do in the environments that we do, as far as I'm concerned, this is not an issue. You also need to remember that it takes about 4 years for these cells to cycle in and out. So let's assume you massively dropped your omega-6s today and increased your omega-3s. It's only 4 years from now that you're going to have all of your cells as healthy as what you would like them to be. So it's a good time to start is right now. So how can we boost our omega-3s? Cold water fish, taking supplements, but make sure that the supplements you're taking are sustained and mercury-free sources. And there's a large study in the late 90s that showed nearly a 1/3 reduction in mortality if you gave high-dose fish oil to patients that were at high risk. This was not standard patients, high-risk patients. There is an upper limit to this, though, so you don't go crazy on the fish oils, because there is the possibility of actually creating a bleeding risk, and we guide the patients as to what to do. So we know that omega-6 fatty acids are found in high doses in seed oils, but it's less well known that if you grain feed your animals, this is what happens to their omega-3s over time. And what happens to their omega-3s? Well, the omega-6s replace them. So basically what you need to understand that if you're not eating grass-fed or pastured animals, you're automatically getting lots of omega-6s. So if we look at your omega-6 to 3 intake, this is the standard Australian diet at the moment. It's about 15 to 1 omega-6 to omega-3. Well, there are quite a few studies now showing if you can drop your 15 to 1 down to 5 to 1, you're going to get a reduction in asthma. If you can get it down to 4 to 1, you're less likely to get a heart attack. If you can get it down to 3 to 1, you can benefit rheumatoid arthritis. Now, my brother is actually one of these people. He was a severe asthmatic. He couldn't eat fish, he couldn't eat dairy, couldn't come over to my house because I had dogs. After 6 or 7 months on this diet, weight loss, changing the food, he hasn't used any of his asthma medication at all. He eats fish, he eats dairy, and he can come to my house. So we have real practical proof that this works. You make people less inflammatory, they eat less inflammatory, they live less inflammatory.
How do you know you've got a 3 to 1?
Come to us and get the blood test done. No, there's a few labs that can do it for you. Okay? But again, you have to know how to interpret it. So I want to show you another patient from the clinic. So this guy looks actually not too bad. All right? He eats a lot of fish and salad, and you know, in January 2016, his omega-6 to 3 ratio is 3.2. Decides that you're going to go full out on the diet, and you can see what's tracking here. And then basically a year later, he's dropped down to 1.6 to 1. And so he's pretty happy because now his risk of a heart attack or any other cardiac disease has dropped by 50%. Right? Do you know who that person is? Me. All right? So we live this. And this is on a high-fat diet. I eat less than 20 grams of carbs a day. My diet is principally fat with about 0.7 grams per kilogram of protein. So what about the bliss point? The bliss point and reward pathways. The amount of pleasure you feel eating a food includes the feeling of fullness afterwards. So if you feel stuffed after you've eaten something, it's actually not as enjoyable as if you eat something and you think, yeah, maybe I could just have a bit more dessert, right? And so that's where this bliss point comes into it. And you combine fat, sugar, salt, and in many cases caffeine to stimulate the dopamine receptors inside the brain. And there are PET scans that you can do. You can look at how much it lights up over here. And the problem is that obese people become resistant to the dopamine, and so they need more dopamine to get the sense of pleasure, so they need to eat more. These are the same receptors as cocaine, heroin, morphine. These are strong pleasure receptors, and sugar really stimulates them. So that's why we know that sugar is addictive. So what about the difference between glucose and fructose? Well, fructose is much sweeter on the sweetness index. Now we seek sweetness. Soft drinks, very sweet, high fructose or high sugar, we want them to get our reward much more than a less sweet product. So what about artificial sweeteners? There are better ones than others in terms of creating an insulin response, but the problem with the sweeteners is that they stimulate your dopamine pathway. And so if you're someone that is sugar-seeking, staying on a sweetener will continue your sugar-seeking behaviour, and you'll find it much more difficult to stick to any diet. So if you need it as a crutch to get you from sugar to low carb, it's fine to have it for a period of time. But your goal eventually should be to get rid of the sweeteners altogether so you don't stimulate the dopamine pathway. Now, there is some evidence that a lot of them are actually carcinogenic, but again, I'm not going to talk about that here. So the last thing to think about is the polyol pathway, and this is important because when we eat glucose, a lot of it gets converted down into the tissues where we need it, but we discussed the fact that some of it gets converted into fructose. So if you're well, only about 3% of your glucose will become fructose, but if you're metabolically unwell, 30% of it will. So someone that has a fairly normal blood sugar level can tolerate some carbs, but someone that's not won't be able to. And is this reversible? Yes. It's a reliable outcome in the clinic with patients becoming insulin sensitive again and gradually going from this back to this over a period of months. So we now to look at a slightly more practical side of things. Once we stop eating the processed carbs, we reduce our salt intake from about 10 grams a day as a standard diet down to about 1 gram. But the kidney is very sensitive to insulin, and sodium reabsorption relies on insulin. Because you've dropped our insulin, we're going to wee out a lot more sodium. So this gives people what you call the keto flu within the first 4 weeks until you adapt. But you can get rid of all of these symptoms, dizziness, headaches, lethargy, dry eyes, constipation, thirst, just by adding salt to your food. My favourite thing is just to get a miso soup, which is very salty. A lot of people drink bone broth as well. So how much salt should be adding? There's a study of over 100,000 people that showed that between 4 and 5 grams a day of salt was the optimal level. We're at about 10, which is not too bad for a standard Australian diet. If you drop down here, it's actually more dangerous for you than not doing anything. You're more likely to die here than here. So really, about 4 teaspoons of salt throughout your food during the day. So how do we tie all this together? Well, you come to the clinic, you see the doctor, take a full medical history from you, tests are ordered according to your health. This is a DEXA scan, so a dual energy X-ray absorptiometry, and what it does is it looks at your body composition. And this is a patient who started off here and dropped to here, and you can see the difference in the amount of fat in their body. So the second visit, you get a food diary, ketone monitor, sample recipes, but most importantly, you learn how to read a nutrition label. And this is a chocolate spread which a lot of people use for their kids for lunches on bread. And when you look at what's in it, palm oil, sugar, how much sugar? Well, nearly 60 grams per 100 grams of sugar. And we're giving it to our kids for lunch. So what about things that are labelled as healthy? Well, here, look, this is organic and it's almond milk. That's got to be good for you, right? But flip it over, organic almonds, organic agave syrup, that's fructose, organic sunflower oil, that's omega-6s. Do you really want to be eating that? Very important to understand. So just to remind you over here, high insulin, low fat burning. So how do we know what's happening? Well, we have breath, urine and blood monitors, but there's no doubt that the blood test monitors are the most accurate. And you can tell how much fat someone is burning by the amount of ketones in their blood. But it'll depend on what your goals are. A ketone level of 4 won't necessarily be better than a ketone level of 1 for weight loss, particularly if you're eating lots more fat than what you should be. So a metabolically unwell person will have very low limits, but a metabolically healthy person may have higher limits. So how do we know? Well, we get you to do a food diary. And the food diary is very important because here's a person tracking their ketone levels doing really well. 1.1, 0.7, 0.4, all good for weight loss. Small piece of sponge cake, what happens? Drop down to 0.2. So we know that for this person has created the ketone drop. They get back up to 0.7, they have a small piece of toast, they drop back to 0.2. So we can track for you, and you can track yourselves, what you can eat and what you can't eat to maintain yourself in a fat-burning state. So this is an example of one of our patients. Here's his pants before, this is his pants after. He saw me, he wanted a knee replacement. I said to him, look, let's do a deal. You do the diet for 3 months. At the end of that 3 months, if you're not better, I'll do the knee replacement for you. Now, he was on 100 units of insulin a day. 100 units of insulin a day. By the time he was halfway through, he was down to 30 units of insulin a day, and he's cancelled his knee replacement. And in fact, so far, pretty much 50% of the patients that I send into the clinic, because I don't see the patients at the clinic, Paul does, cancel their knee replacement surgery. And I guess that's why I've got time to be standing here today. So what haven't I covered? Well, there's a lot of stuff I haven't covered. It's not possible to cover everything in a talk like this. But I do want to give you some take-home messages. Insulin is a major part of obesity. Carbs make you fat, especially sugar. Saturated and monounsaturated fats are fine if you're not eating carbohydrates. There needs to be a balance between omega-3 and 6 fats. Salt isn't that bad after all. Artificial sweeteners make you hungry. And the question is, how do we make this sustainable? The key is to make it a low carbohydrate, moderate protein, high fat diet. Now, green leafy vegetables are great, okay? I use them to get extra fats into me. Everything I cook is covered in oil or lard or anything like that, because I can't eat the fat unless it's with something else. Personally, and I love salads and veggies, and that's where my carbohydrates come from, is that, and that's why I coat the fat with it. So, no polys where possible. Sodium, 4 grams a day, magnesium for muscle cramps. If you're eating a whole animal, the kidneys, the liver, everything else like that, you're not going to need magnesium because there's plenty of magnesium in those organs. But our general diet, we don't get the magnesium from those substances. Now, the other thing is, if you do break the diet a little bit, it's okay. You're not going to die from being out of ketosis for a day or two. You are going to get your sugar cravings, you are going to not feel so well, but at the end of the day, you can get back onto the diet and be fine. So, as with all things in nutrition, there's lots of ways to think about things. But from my perspective, what you need to do is this. Keep your insulin low, eat healthy fats, avoid addictive substances like sweeteners, fruit occasionally and never drink it, measure your ketones and don't guess, and enjoy a healthy life. So what I'm going to do is ask Paul to come up here and join me, and he and I can field about 15 minutes worth of questions if you have any.